good mental health and well-being for everyone. We work together to provide services that we are proud of, and we work with our service users, with carers and with our commissioners. We challenge the way we all think about, talk about and respond to mental health, and we use our profile to influence and improve people's lives. We have a service pathway, and as you can see, people can come in at varying levels of needs. We've got crisis intervention services, which includes the crisis house, homelessness service, hospital to home services. We've also then got tenancy support, floating support, supported accommodation, we've got employment services. We've also got resettlement from prison alongside employment services. So specifically what we're going to look at is the crisis house model. That's okay. Do you want to go over? It's been operational since 2006. It came about through a lottery funding bid, which was partly funded alongside the Health Board. It was a leap of faith. It's the first one in Wales. It's the only one in Wales. It's a 4-bedroom residential property. It's actually owned by the Health Board, but it's actually staffed by ourselves with our Goval staff. It's a collaborative arrangement with the Cardiff and Vale University Health Board, and it's part of a wider network of crisis services, so it fits alongside the crisis teams. There's a crisis recovery unit alongside what we provide within that. And it's run by ourselves, as I said, but there's a lot of clinical support which is accessible to our staff, to our service users who engage and who stay within the property. It was founded on the principle that people experiencing severe mental health difficulties should be supported in the least restrictive environment, and to hopefully promote the minimum disruption within their lives. So it's trying to make sure that it was really holistic, it was therapeutic, and it was comfortable for that individual to promote recovery. It very much serves the patients of the crisis team. The only access to the team is referral through the crisis services, and provides intensive support to individuals in the crisis house as an alternative to inpatient care and in a non-institutional environment. Obviously, the objectives of the house are to avoid hospital admission, facilitate early discharge, promote service user choice, be actively involved in the provision of support to facilitate a return to the individual's home, provide practical and emotional support, and to individuals who experience an acute psychiatric crisis. Our access criteria is accepted by one of the crisis resolution home treatment teams. There's 2 which serve the Cardiff area, and needs to be considered as appropriate for hospital admission. What we do find is less likely to respond to those with mild anxiety disorders or primarily a diagnosis of alcohol or substance misuse or organic disorders. What we find is very much led on the individual, and it's a case-by-case need. So somebody, for example, with severe depression who may have risk of suicide or risk of self-harm would easily access our crisis house. There's no blanket rules, as I said. It's very much on a case-by-case basis, and the referral is dependent upon assessment of the crisis resolution teams. The support we provide is 24-hour waking cover with high staff-to-resident ratio. We work at a minimum of 2 to 4. It's a therapeutic, homely environment. Intensive social and emotional support planning. We work on the basis of the Recovery Star, which covers 10 lifestyle areas. So we look at people managing and maintaining their mental health. We look at physical health. We look at daily living skills, financial. Literally, we cover the whole area within that. And what that allows is the individual to identify where they are within there, and we look at a ladder of change to implement that, where they want to be, and the support then that we can provide or other services can provide for that person to meet their ultimate aim, which is about recovery. We provide support with daily living skills. So when we're looking at in a hospital environment where you're given your meals within the home, you're encouraged with staff and support to actually prepare your own meals, make your own meals, maybe go out and buy your own food. Same with doing your own laundry as well. So it's very much keeping that environment as as non-intrusive as we possibly can. And we also then look at signposting to other services, what other services are available for that person to access when they leave in the crisis house, because usually people stay there for up to 7 days, maximum is up to 14 days. We also then liaise with carers, so we look at what some of the needs are for the carers, what support services are available for carers. So we very much look at the whole package of what's going on for that individual. Obviously, alongside that, we make observations and we liaise very closely with the crisis team because they get an idea then of how that person's coping within that homely environment. What we have is a service user profile, and this has been like contributing factors which have been identified by the crisis team. And there may be previous history of hospital admissions. Person may be living in poor living conditions. Risk cannot be managed by home visits alone. Maybe abusive relationships, something within the home which is causing or exacerbating the crisis. And alongside that is self-neglect as well. The reason for referrals are carers needing respite from crisis, less stigmatising than hospital, easier to maintain social networks, and it's the ability to carry out a fuller assessment of daily living skills to see how that person would cope when they return back home. From the service user perspective, a significant number of people who access our crisis house have experience of hospital admission. 95% of service users have rated the house as good or excellent in comparison to hospital. 89% have come back and said it's excellent. 99% felt that they had good or excellent access to staff, and 95% felt that the benefit to their mental health was good or excellent, and 81% stating it was excellent. Some of the figures we have had is over 600 referrals since we've been operational. 85% of that's been hospital avoidance. Average length of stay, as I said, is 7 days. It's fluctuating occupancy depending on what the needs are of the individuals and the access to the crisis team. And 83% of service users previously admitted to hospital had experienced longer stays than that of the crisis house. What we do know is the crisis house model is viable and it's an alternative to hospital admission, and it very much is an alternative. It's not instead of, it's an additional resource for the area. The service needs to be designed according to the local need, and geographically you need to look at where a crisis house may be in regards to access, transport issues. Is it rural, is it urban, and the demographics. And it's very much a collaborative approach and provides holistic care and support. What am I doing? Can we go back one? What we have thought is that the service could be improved by the benefit to service users by the provision of respite and crisis prevention. Currently it's an intervention service more than prevention, but there's people we know historically, if they could access the service sooner, who could possibly end up in hospital through previous histories. We could actually make a difference that way. And I think it's already been highlighted in a few of the presentations this morning. It was about peer support, and part of that is actually developing the people who access our services to actually then become a peer and actually support other people who are going through that mental health crisis, because that does look at the whole recovery and look at employment, volunteering and engagement as well. Is that okay? Thank you.